So let's go back to the alternative payment model world. And again, this is kind of a reminder to you. Kathy's talk was really focusing on the fee-for-service program, which is very important, but it's also good to realize that other things are going on. And today we've got about 5 million Medicare beneficiaries out there who are being served by ACOs. That doesn't mean the ACO is providing all their services. What it means is that the ACO in the Medicare program has agreed to be responsible for those services in terms of quality measurement and in terms of total resource use. And the advantage for the ACO, potentially, is if those beneficiaries they have taken responsibility for, if you will, if expenditures for them are lower than what the program has predicted, then they will share in savings. And so this is a tremendous incentive for them to change the way they are caring for their patients, and a lot of people hope that it's changing it in the right direction. It's not been going exactly terrifically well so far, because even the fairly sophisticated organizations that signed up in the early rounds of this program are really having trouble and they're struggling. But nonetheless, about 25% of them in their first year under the Medicare Shared Savings Program were able to produce enough expenditure reductions to gain some shared savings. Now, there's all kinds of controversies going on right now, and a lot of the ACOs actually are threatening to leave. They're unhappy for a variety of reasons, and I'll say more about that in just a moment. But what I want to do now is just show you this, and this is an updated one from the one I showed last year. And what this is an indication of is the concentration of ACOs in the different parts of the country. So depending on where you're from, if you're from Iowa or whatever, you can go to the map and look and get a sense of the concentration of the ACOs. This is just Medicare now. This has nothing to do with the private sector, and there's a lot of ACOs in the private sector as well. So in some parts of the country, New England, California, Florida, we're seeing fairly concentrated numbers of ACOs. So what this might mean is that the patient you're seeing that's a Medicare patient might actually, at the end of the year, find themselves attributed to one of these ACOs. And so this whole issue is a fascinating one, and we could spend a great deal of time. But I just want to touch on a couple of things. One is that the Medicare program is promising to bring out a new regulation, a proposed rule later this year on the ACOs to make some changes. And some of these changes could be far-reaching, and we'll just have to wait and see. And I think part of this exercise is an attempt to try to give this ACO program a fair run. That if there are some problems, to try to address them through rulemaking so that the ACO program can continue to go forward. But certainly the jury is still out. But nonetheless, what the program has been saying is they'd like to go beyond what they have. They'd like to start putting ACOs at full risk, or they'd like to start making the ACOs be accountable not only for Part A and Part B covered services, but also for the Part D, the prescription drug program costs. And some of this is coming from the drug industry, because if you have a drug that's paid under Part B, and your competitor has a drug paid under Part D, then the ACO can use the Part D drug and it doesn't count. But if they use the Part B drug, it gets counted against them, or if you will, in terms of whether they can control expenditures or not. So there's certain dynamics that go on there. And the other thing they are very interested in, is noted, is they'd like to then combine the Medicaid and Medicare and make the ACOs take responsibility for all of that. So again, this is sort of a sense of where the program would like to go over time. Now, I'd like to shift gears, and this slide I've shown you before, but again, I want to remind you there's a lot of other activity going on, and right now you're probably not paying very much attention to it. And this is the bundled payment initiative that's going on in the Innovation Center portion of CMS. And what they've done is, now the reason you're probably not paying attention to it is this program for now is only focusing on inpatient procedures. So in order to be relevant to this new model, this new test, the patient has to start with an inpatient admission to receive the service. And from then, the bundle kicks off in a variety of ways. And as you see there are 4 different bundles being tested. Now, in the first 3 bundles, everybody gets paid like they've always been paid. So it's not a bundle payment in that sense. But there's a reckoning at the end of the year. And that reckoning says, all those individual bills that came in for all the people that were providing the bundle, did it add up to more than what the program had estimated or less? If it's more, you're going to owe the government money. If it's less, you're going to get to keep the difference and spread it around the people who were involved in providing the bundle of services. And I'm oversimplifying a little bit, but I just wanted to kind of give a general sense. Now, what's different about Model 4 is that, and you see that model combines inpatient services, including not only what the hospital did, but also what the physicians did during the inpatient stay. And under that model, it's the hospital that gets the payment. And it's the hospital that has the responsibility for divvying it up. So again, that's a very different kind of bundle payment. But this is the kind of thing that's being tested, and you say, well, so what? You know, it's not that important to me. But I think what I want to point out, I was actually shocked by this because I went to the Innovation Center's website, and what I found was that there's 6,800 organizations out there in the country that have raised their hand and said to Medicare that they would like to participate in this bundle payment demonstration in one way or another. And so there's tremendous interest out there in rolling this out. And the other point there that's made on this slide is that the program is also interested in moving beyond where they are, and this is where you need to pay more attention, because what they're talking about is starting to create bundles for outpatient services, including episodes of care, for example. So that might affect if you're providing care for a diabetic or an asthma patient, the primary care physician might get a bundle per episode payment rather than fee-for-service for every visit. Similarly, they might create a bundle around certain outpatient procedures and cover all of the care that's provided for some period of time, even if that care is provided by a variety of folks. But we have bundled, at least for the moment, we still have bundles, global surgical bundles, but this bundle would be even beyond all of that. So again, I wanted to share with you some of this. In addition, I want to talk about two other initiatives the Innovation Center is pursuing. The first one, I think we've talked about before, and this is kind of like a medical home. So for just almost 500 practices around the country in 7 markets, what they're testing is this concept of paying the primary care physician a per member per month fee of about $20, and for care management, if you will, care coordination and those sorts of things. And the additional advantage for these practices is if they do a good job, and from the program's perspective, if they reduce spending, then again, there will be shared savings that can be produced. So again, this certainly, if you think about this and what the incentives are, certainly could change referral patterns. It certainly could change a lot of things in the way these patients are managed, and also provide incentives to make sure that spending is reduced, that if in fact you can take care of that patient in your office and promptly and carefully, and instead of having them go to the hospital, then that would be a tremendous advantage for this particular practice. So that's one of the initiatives, the Comprehensive Primary Care Initiative. And this other one that we've never talked about because it's brand new, just was announced late last month, it's Transforming Clinical Practice Initiative. This is a little squishy for me, I have to be honest, but what the program has announced is they're committed to almost $1 billion over the next 4 years, and they're going to roll out a variety of amounts of money to 2 types of organizations: practice transformation networks and support and alignment networks. But the bottom line here is what they claim they want to do is to help about 150,000 clinicians in the United States to do a better job, to transform their practice in a variety of ways. So what are these new networks? Well, the examples that have been given for the first one is that they could give money to quality improvement organizations, which already do business with Medicare, or maybe to a large health system, or maybe to a large medical group practice. And this would be money that they would use to work with the clinicians, improve care, and so on. And the other group actually could include even an organization like APMA. And suddenly, somehow, through continuing education, through a variety of other programs, these associations or medical specialty societies would be assisting their members to transform care. It's clearly well-intentioned. Clearly they see there are issues out there in the way medicine is practiced in the United States, and wanted to find a way to for improvement. So again, stay tuned. This one here, the deadline for submitting applications is January 6th, and sometime by next spring or summer, they hope to be rolling out the first amounts of money to support this whole initiative.